Sarcoidosis is a multi-system inflammatory disorder usually characterized by non-casein and granulomas. While this disease most commonly affects the respiratory and lymphatic systems, extrapulmonary manifestations involving the brain and heart occur in approximately 5% of patients. Neurosarcoidosis may cause dysfunction of the cranial nerves, meninges, peripheral nerves, or the pituitary system. Cardiac sarcoidosis may lead to arrhythmias, cardiomyopathy, or heart failure. These specific diagnoses can be challenging as they can masquerade as isolated pathologies. In this paper, we present a rare case of systemic sarcoidosis with concomitant neurological and cardiac involvement. The patient is a 59-year-old female with a history of bilateral anterior uveitis and no prior significant neurological or cardiac disease, who presented with facial droop, aphasia, and headache. Associated symptoms included nausea, neck pain, blurry vision, and hand paresthesia. Stroke workup consisting of head and neck imaging showed normal vasculature and enhancement and no acute hemorrhage. A computed tomography of the chest, abdomen, and pelvis was ordered due to nausea, which identified a prevascular lymph node. A transthoracic echocardiogram noted moderate mitral regurgitation, biatrial enlargement, and a preserved ejection fraction. No interatrial shunt was seen. Several days later, the patient developed pulmonary edema, and a repeat TTE showed worsening mitral regurgitation and elevated pulmonary artery systolic pressure. An infectious workup, including lumbar puncture, yielded cerebral spinal fluid analysis with lymphocytic pleocytosis, elevated total nucleated cells and neutrophils, glucose, total protein, albumin, IgG, and IgG synthesis rate. Aseptic meningitis secondary to neurosarcoidosis was suspected due to the history of bilateral uveitis, abnormal CSF studies, and prevascular mediastinal lymph nodes. Steroids were begun with significant improvement of symptoms. The patient exhibited sustained ventricular tachycardia. Right and left heart catheterizations were performed, which showed severe MR and non-obstructive coronary artery disease. Cardiac magnetic resonance imaging was then completed and showed extensive mid-myocardial and epicardial non-ischemic enhancement. Left ventricular EF was noted as 46% with dysynchronous contractility. These findings, when correlated with clinical history, were found to be consistent with cardiac sarcoidosis. A biventricular implantable cardioverter defibrillator was implanted due to the increased risk of sudden cardiac death secondary to extensive cardiac scarring and sustained VTAC. The workup of systemic sarcoidosis is oftentimes extensive, requiring thorough evaluation of various extrapulmonary manifestations. The patient outlined above initially presented with stroke-like symptoms, and only after ruling out stroke and infectious etiologies was neurosarcoidosis and subsequently cardiac sarcoidosis discovered. This meticulous process may delay the final diagnoses and the treatment, leading to worse outcomes. It is therefore crucial to consider comprehensive workups early on when addressing systemic diseases.